We're going to cover detection of pneumothorax with lung ultrasound. A very exciting topic and one that I think you'll find clinically relevant. It really all starts with this very simple artifact with huge ramifications. This is lung sliding. This is a demonstration of the interaction of the parietal and visceral pleura. A literal sliding of these two membranes against one another. As demonstrated here, it's this scintillating hyperchoic line, which is straddled by two rib spaces. This means that the pleura is interacting with no intervening air space. This is really the basis for this talk and help generate our learning outcomes. So we're going to talk about developing a consistent approach to performing and interpreting lung ultrasound to really help us detect and rule out pneumothorax. We're going to troubleshoot lack of lung sliding in a patient with respiratory failure and detect procedural complications immediately at the point of care. You'd be surprised to know that sensitivity lung ultrasound for pneumothorax approaches 90 to 95%, and certainly in select cases, nearly 100% when the pleura is highly visible. Chest X-ray demonstrates sensitivity somewhere around 45%, particularly in the supine patient, where air spaces are seen more ventrally. Certainly lung ultrasound is fast, it's reliable, but also many times the machine's already in the room for performing vascular access procedures, so it's well at your disposal. In many cases, X-rays leave much to be desired, particularly in the unstable patient who can't be mobilized, or is perhaps hemodynamically unstable. Again, in a supine patient, we're left often looking for either a large pneumothorax or that dreaded deep sulcus sign. How do you perform lung ultrasound? Well, traditionally, we perform lung ultrasound at 4 different points. Point 1 is the midclavicular line around the third intercostal space. Point 2 is the anterior axillary line, roughly the 4th to 6th intercostal space. Point 3 is the mid-axillary line, just in the lowest costal space. Point 4 is really the posterior thoracic space. Now, this exam is really tailored when you're examining for pneumothorax because it really depends on where you think the airspace is collecting. So you'll see we'll adapt this exam as we go on here. To perform this exam, we can use a convex probe, a linear probe, or a phased array probe. My preference is to use a phased array probe because that probe can also be used for cardiac examination and even abdominal examination. However, in selected machines, it does not offer the same standard of pleural resolution. Therefore, the linear probe, this is where it really excels because of its high frequency but low depth of penetration. We place the probe marker in the cephalad position, and generally speaking, the image is acquired in the sagittal or parasagittal plane, as demonstrated here. You'll notice the screen marker is left-sided in traditional radiological convention. In this case, we see a rib and rib shadowing, followed by the pleural line, followed by another rib shadow. This is often called the batwing appearance of lung ultrasound. So we're going to review 5 important lung ultrasound findings to detect pneumothorax, which if you become facile with, you will find you'll perform this examination with ease and with confidence. The 5 findings are lung sliding, A lines, lung pulse, lung point, and B lines. Let's start with lung sliding. Again, this is a visual demonstration of the interaction of the parietal and visceral pleura. Lung sliding cannot be seen if there is an intervening airspace. So in this case, we're using a phased array probe. Again, if you're having difficulties using a phased array probe, you can switch to a linear probe to offer higher pleural resolution, which is seen on screen right. Because this is also a tissue-air interface, there's often lots of reflection at the pleural line. And this generates an artifact known as a reverberation artifact. And this creates duplicates of that pleural line, called A lines. A lines plus lung sliding reflect a normal healthy parenchyma. Importantly, you will still see A lines in pneumothorax because there's still a tissue-air interface. So A lines by themselves do not rule out pneumothorax. Importantly, you'll notice the depth is around 6 to 10 centimeters. That's the approximate depth we set it at for the anterior chest wall. When there is sliding, it means that there's complete pleural apposition. The pleura is unfused, and there could be no pneumothorax at that site. We can use this finding before and after procedures, including intubation, to confirm equal lung insufflation. As if you intubate the right main stem, you will see the left lung stop sliding. And that's because with the cuff up on the right main stem, the left lung will begin to collapse. This can also be used before and after line insertion and thoracocentesis. This can really expedite the diagnosis of pneumothorax. The absence of sliding, as demonstrated in this image here, shows no movement or no scintillating artifact along the pleural line, or the quiet pleural line. This can certainly occur in pneumothorax, but there are other important considerations you must incorporate when you're applying this finding. Again, as I mentioned previously, main stem intubation, particularly more common on the right, so there'll be a lack of lung sliding on the left. Apnea, pneumonia, and atelectasis can occur, especially when there are large, dense lobar consolidation, where the lung is no longer inflating at that site. Finally, pleurodesis, or localized thoracic instrumentation, can lead to scarring of the pleura, resulting in no actual sliding and movement with insufflation. So bottom line, the sensitivity is higher than specificity. So importantly, lung sliding rules out pneumothorax 100% at that site. And so it's important to consider that you may need several sites to make sure you rule out any significant airspace. And you must consider position of the thorax during scan, which we'll get into briefly. If you find a lack of lung sliding, your next step should be looking for a lung point and really comparing versus the contralateral hemithorax. If you can find a clear discrepancy between both thoraces, then it certainly increases your suspicion. Again, if you return to the thorax with lack of lung sliding and you find this finding, this certainly increases your suspicion. This is called the lung point. The green arrow here shows clear pleural interaction and sliding. The white arrow shows a lack of lung sliding. And so it's really this junction which elevates your suspicion greatly of a pneumothorax. It's because this is really, again, the point of pleural apposition and non-apposition. As shown on the CT scan here, we can see that there is this junction of non-apposition and apposition. And this is what you're looking for at a lung point. But again, this really depends on the position of the patient during the scan. So if they're laying supine, as shown on the CT, you'll often find it laterally displaced, this junction. If they're sitting upright, you may have to scan along superior to inferior to find this same junction. Again, just to highlight that air rises to non-dependent areas of the thorax, and so you really have to consider this when applying these lung findings. There are also other findings to rule out pneumothorax. B-lines, shown on screen left, are these hypercoag artifacts that extend from the pleural line in the near field to the far field. I'll talk more about these in a couple of minutes. On the right side, we see lung pulse. You'll notice this doesn't look quite like lung sliding. This looks more like, you guessed it, cardiac oscillation. And so the pleura is still interacting here, but it's largely a reflection of cardiac oscillation rather than lung insufflation. Next, moving on to B-lines. We'll discuss these briefly. B-lines rule out pneumothorax at that site. Theoretically, they reflect thickening of the interstitial septae. Even if there is no lung sliding, if you see B-lines, you can safely say there is no pneumothorax. They may, however, have pneumonia, atelectasis, pulmonary edema, or ARDS if you see a lot of them. B-line characteristics, they ablate A-lines where they cross, so B-lines always take predominance. They extend from the pleural line down to the far field. There are some lines which will only extend a short distance from the pleural line, but not to the far field. These lines are of undetermined significance, but are often called Z-lines. B-lines move with lung sliding. When we see an airspace or a lung ultrasound which goes from predominantly A lines to predominantly B lines, we almost always think fluid's the cause, but that may also include ARDS. And when we see more than 3 B lines at one site, that further increases our suspicion of an acute interstitial syndrome, such as pulmonary edema or ARDS. So those are the 5 lung findings. And again, I would urge you to either rewatch the video or study these findings to really get a sense of how we use these in the resuscitation room. Back to our learning outcomes. We talked about developing a consistent approach to performing and interpreting lung ultrasound to detect pneumothorax. We discussed troubleshooting lack of lung sliding in a patient with respiratory failure, including apnea, main stem intubation, pneumonia, and atelectasis. And detecting procedural complications immediately at the point of care in instances of intubation and central line insertion.